Hi, Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine here. Welcome to our video series for students and professionals. We've got our website here, facebook.com/sparkspeds, and that'll also direct you to our actual website if you want to look at some static materials that we've prepared. And our phone number, area code 775-359-7111. We are taking new patients and contract with most insurance companies in the area as well as nationally. So if you are looking to refer somebody to us for consultation, we're happy to see them here. However, do be aware we can't really provide much in the way of help over the internet or over the telephone because it's just not good medical care. Whoops. Today, what we want to talk about is a question that keeps coming up from my students. And so this is apparently an area of a lot of concern for a lot of people. Let's see if we can get the pen here to work. It is tetralogy of Fallot. Now, this seems to provide a lot of grief for a lot of people, and I wanted to do this lecture not so much to draw pictures to help you to visualize it, but to intellectually walk you through it. Before we do that, we do want to discuss a few things. The first is the fact that in the modern world, most of these kids are corrected very quickly, surgically. So you don't see a lot of patients with uncorrected tetralogy of Fallot walking around. And that's important because you read an awful lot about Tet spells. And in fact, they like to ask a lot of questions on exams about Tet spells, and these are periods. This is a cyanotic, so we'll put that in blue here just to help with the visualization. It is a cyanotic lesion. Okay, and in this, the kids, if they're pink at rest, will suddenly become blue. And then get very sick from this. They can just go into sudden heart failure and not be reversible if this happens. They will self-treat by squatting down. This increased systemic venous return to the heart and helps to reverse the Tet spell. Therapy for this, if it happens, is morphine, sulfate, and it is given emergently, as in now, so no screwing around. Should this happen, you're not going to see a lot of Tet spells in the real world, though, because again, most of these kids are picked up pretty quickly. The only time you might see it is in a kid who has never been picked up. The other thing I want to mention, this is what's referred to as a contruncal defect. And you'll have to excuse my bad spelling here. And as such, stuff like this, stuff like truncus arteriosus, can be associated with the George syndrome. If you have a patient with Tet, corrected or otherwise, make sure that they've been tested for DeGeorge using a fish probe, 21Q11 minus. Let's get rid of that second minus. And I have seen just a patient who was cared for by a real good cardiologist, had an excellent surgeon, and never had a fish probe. And turned out the kid had low calciums and low T4 counts as well, as would be expected in DeGeorge syndrome. This is, of course, important for predicting immune function. This is also important for predicting some other problems with speech and with intellect as well. So now what is it I would like you to think about in the case of Tetrology of Fallot? What I want you to consider is this. Tetrology of Fallot is, I submit to you, not 4 defects, but rather 1 defect and its pathologic consequences. What do I mean? It starts with an overriding aorta. But what happens when you have a large aorta coming off of the heart, formed at the same time and from the same embryologic anlage is the pulmonary artery? But that means your pulmonary artery must be small because it's squished by a big aorta. What happens if you squish a vessel or a hose running water through it, for that matter? You increase the pressure. So the first consequence is that you have increased pulmonary artery pressures. That makes sense because you've squished it. You squished it because you had an overriding aorta. Now, if you have high pressures in the pulmonary artery, backing up the flow through the pulmonary artery, then the chamber that pumps to that pulmonary artery has to work harder. What happens if you work a muscle harder? It gets bigger. That's great for my biceps, not so good for the right atrium. So you get right ventricular hypertrophy. But that's simply a consequence of the increased pulmonary artery pressure. Number 4, this is a cyanotic lesion, and it is fatal even in fetal life. So how does one deal with a fatal lesion, a fatal cyanotic lesion? One must mix the blood somehow. How does one mix the blood as a fetus? Well, one can do that with a VSD, ventriculoseptal defect. Another way of looking at this, rather than looking at it this way a little more teleologically, if you have high pressure shooting across a small hole, when that septum goes to form, it's not going to be able to do it because of the pressure shooting across the hole. That hole is made because of the increased pulmonary artery pressures and stuff backing up into the right ventricle. Go build a mud wall in your backyard. It's easy. Go build that same mud wall in a stream. Well, if it's a small little creek, not so difficult. Now go build it in a rushing river right after spring flows. Good luck. Same thing here, building the ventricle's septum during that time of high pressure, because you have increased RVH, or increased pulmonary artery pressures resulting in RVH, all resulting from the overriding aorta, which is squishing the pulmonary artery. You know, if we wish to take this out in untreated patients to extremes, I could list a few other things. Congestive heart failure, right? Because this results when you have uncontrolled RVH, and cyanotic heart failure. I could list pulmonary heart-lung failure, or pulmonal. Let's call it by its medical name. Why would you develop pulmonale? Because you have increased PA pressures, and you can reach a point where those PA pressures become fixed, and then the lungs themselves start increasing the peripheral pulmonary arteries to the point where you go into heart failure. I could list number 7, heart-lung transplant. Because that's a consequence of pulmonal. You know, we don't, whoops, I'm making a mess here. We don't list those things, but we could. So I could call it the heptology of Fallot. I can keep going, too, and just keep, 8, death. We stopped with 4. But they could have listed, multiple consequences. The reality, though, is that it's all right here, and overriding aorta. When you think about it this way, it makes it very easy to think about. This is also a good way to learn what's going on in the heart and the circulation in multiple heart defects, including a good way to think about something like hyperplastic left heart, transposition of the great arteries, total anomalous pulmonary venous return. It's a useful thought exercise for all of them. But this one's a very simple thought exercise, and this is why this is such a popular test question, because it forces you to walk through the consequences of changes within the heart. For that matter, if you do adult medicine, this is a good way of thinking, what happens if you have severe mitral regurg? What happens if you have aortic stenosis? Or mitral stenosis, because you have to just walk through. We start at the top of the heart in the right atrium, and what happens if there's a problem? Where does that blood go from the right atrium? It goes through the mitral valve. Well, what if there's a problem? Sorry, I'm starting at the right. I meant to start at the left. So let's start with the left atrium. What happens to that blood if it has difficulty? Where does it go? It goes through the mitral valve. What happens if it has difficulty there? We get it through the mitral valve, then it's in the left ventricle, and what happens to it is it's sitting there. Where does it go from there? It goes through the aortic valve. Well, what happens if there's a problem with the aortic valve? What happens if there's subaortic stenosis? As it crosses through there, where does it go? Well, some of it goes down the coronary arteries. What happens if there's a problem there? And just work your way through the left-sided circulation, and then come back through the pulmonary veins, and come back through the right side of the heart. So come through the SVC and the IVC, and then work your way through the right side of the heart and the pulmonary arteries, and then finish up coming back through the pulmonary veins and make a full loop. And by walking your way through it, you will figure a lot of this stuff out, and it makes sense, because physiology generally does make sense as long as you're following the same thought process that nature used. Anyway, I hope this can be of value to you and aid in your learning and understanding of something that I know causes a lot of grief for a lot of students, and simplify that as well as provide you a template for thought for many, many complex diseases that cause many a student, many a pediatric resident sleepless nights. And I don't mean taking care of the patients, I mean learning about the diseases. This is Dr. Kevin Windisch. This is our phone number and website or Facebook address, which is much more active than our website. Give us a call if we can be of assistance if you'd like to schedule a rotation. I am a professor of pediatrics through most nurse practice and PA programs in the Western United States, and if you're not in the program that we're with, chances are it's pretty easy for me to become such a professor for an away rotation. I'm also professor of medicine at UNR School of Medicine, and can certainly sign the paperwork for associate professorships at pretty much any medical school in the United States or Canada without much thought if you'd like to do a rotation in pediatrics here. We'll see you next time.